Welcome to a short introductory lecture on pragmatic clinical trials. My name is Robin, and I'm a research associate with the Pragmatic Clinical Trials platform. I will be taking you through the rationale and the basic characteristics of pragmatic clinical trials. After this lecture, you should be able to describe the challenges of traditional clinical research, be able to compare and contrast characteristics of explanatory and pragmatic clinical trials, identify relevant stakeholder groups, recognize opportunities for stakeholder engagement, and list the domains of pragmatic clinical trials using the PRECISE2 tool. Research starts with a research question, and the research question influences the study design. There are two main types of study designs: observational studies and randomized clinical trials. The randomized clinical trial can be subdivided into explanatory trials, which is what most traditional randomized clinical research belongs to, and pragmatic clinical trials. The explanatory trial asks, does a treatment work in ideal situations? Explanatory trials are designed to investigate the cause-effect relationship of a treatment and are performed in a highly defined and carefully selected patient population. Explanatory trials often require additional data collection outside routine clinical care. In contrast, a pragmatic clinical trial asks, does the treatment work in the real world? Pragmatic clinical trials are designed to inform and improve practice and policy. Pragmatic clinical trials aim to guide treatment choices in routine clinical practice by investigating relative effectiveness of treatment strategies using flexible protocols catered to the capacity of clinical practice. The trial designs exist on a continuum, and neither trial is completely explanatory or completely pragmatic. Both explanatory trials and pragmatic clinical trials incorporate random allocation of participants to treatment groups to promote internal validity and comparability. Pragmatic clinical trials and observational studies are considered real-world evidence, which provides evidence on effectiveness. This results in more context-appropriate evidence for clinicians and policymakers. Real-world evidence is generated by synthesizing data that is used for decision-making that are not collected in conventional explanatory randomized clinical trials. This includes synthesizing data from real-life healthcare delivery settings, insurance claims, and clinical data from electronic health records. Real-world evidence aids in decision-making and policy formulation by combining high-quality evidence that is patient-oriented, which is relevant to clinicians and decision-makers. Real-world evidence addresses the needs of clinicians and decision-makers by providing evidence on which factors contribute to success and what would make it more effective. The aim of real-world evidence is to improve the generation and translation of research into practice through engagement, partnership, and collaboration. Pragmatic clinical research is designed to produce high-quality, patient-oriented evidence. Evidence is generated by partnering and engaging with health professionals, clinicians, researchers, industry, and patients in the evidence generation process. This aids in integration and translation of research into policy and practice. To demonstrate efficacy, explanatory trials are performed in homogeneous patient populations. For example, in explanatory trials, patients are carefully selected with well-defined characteristics for the clinical condition of interest. Patients who are older with comorbidities tend to be excluded to minimize confounding when evaluating treatment effects. To demonstrate effectiveness, pragmatic clinical trials take place in routine clinical practice and are designed to include and incorporate variations seen between patients. This heterogeneous patient population, with varying level of comorbidities and age, reflect clinical practice. Usually, in pragmatic clinical trials, there are very few, if any, selection criteria, other than the presence of a disease or a diagnosis of interest. In explanatory trials, treatments are usually strictly enforced and closely monitored to ensure adherence. Data collection and patient follow-up are often intensive and mandatory in explanatory trials. Explanatory trials are often performed in tertiary centers. In pragmatic clinical trials, treatment regimens are often administered in routine clinical care and tailored to the patient's needs. For example, patients do not necessarily all receive the same treatment. Data collection and follow-up requirements are kept to a minimum to mimic usual care. In explanatory trials, outcomes tend to be surrogate markers that are used to demonstrate treatment effect. In pragmatic clinical trials, outcomes tend to be patient-centered and include patient symptoms, overall mental state, and quality of life. The goal is to measure the effects of a disease or condition on how the patient functions. Explanatory trials usually take place during the development of a health technology and are driven by an investigator or a drug developer to demonstrate the technology works and is efficacious. Pragmatic clinical trials are usually performed after health technology has been demonstrated to be efficacious and are driven by patients, providers, and policymakers to demonstrate effectiveness in real-world settings. The focus is on application and implementation. Central to pragmatic clinical research is engagement, partnership, and collaboration. Stakeholders are individuals or groups who either care about or are impacted by an entity, task, or project. In pragmatic research, potential stakeholders will be impacted by your research project, the research evidence generated, and its potential results. The 7Ps framework identifies key groups for engagement: patients and the public, providers, purchasers, payers, policymakers, product makers, and principal investigators. Patients and the public are current or potential consumers of patient-centered healthcare. This may include their caregivers, their families, and patient and consumer advocacy organizations. Engagement of the stakeholder group provides opportunities for identifying research priorities, define meaningful patient-centered study outcomes, and provides opportunities for feedback and assessment. Providers are individuals, organizations that provide care to patients. Individual providers may include nurses, physicians, pharmacists, social workers, and other health professionals. Organizational providers may include hospitals, clinics, and healthcare diagnostic centers. Engagement of the stakeholder group is important to provide the context of routine clinical care, aid in the recruitment of patients for a pragmatic study, provide input on relevant patient-centered outcomes, and are a major player in data collection. Purchasers include employers, governments, and other entities responsible for determining the amount of risk around providing a health technology, health service, or healthcare program. Engagement of purchasers of healthcare technologies and services helps define the current financial burden of treatment, helps to set metrics for healthcare improvement, and to assess technologies which may benefit from early adoption. Payers are responsible for the reimbursement of healthcare interventions or medical care and include private insurers, publicly funded healthcare systems, individual patients with out-of-pocket costs. Engagement of the stakeholder group is important to define current financial burden of treatment, provide input into areas of improvement, and input on the reimbursement of new health technologies for improved population health. Policymakers develop and plan courses of action designed to influence or determine decisions or procedures. These include governments, professional associations, and policymaking entities at the federal, provincial, local, or hospital level. Engagement of the stakeholder group is important to identify challenges to effective decision and policymaking, define policy-relevant outcome measures, and provide guidance on existing data sources, and to enact system-level change. Product makers are drug and device manufacturers, information technology companies, or related technology companies that provide a healthcare product. Engagement of this group is important for sponsorship and initiation of research to define meaningful outcomes and to provide solutions to healthcare needs. Principal investigators are responsible for the management and integrity of the study design, conduct, and reporting and dissemination of research findings. Engagement of this group is important to ensure research is high quality, to provide feedback and assessment throughout the duration of the study, and to analyze and disseminate results to relevant stakeholders. Pragmatic clinical trials are designed to improve clinical practice and policy by answering questions from and important to stakeholders through investigating the relative effectiveness of real-world treatment strategies and diverse representative populations in routine clinical care using multiple outcomes relevant to decision and policymakers. The Pragmatic Explanatory Continuum Indicator Summary, PRECIS, is a tool to help design a trial for the intended purpose. The PRECIS tool has 9 domains, scored from 1 to 5, where 1 is highly explanatory and 5 is highly pragmatic. The 9 domains are eligibility, recruitment, setting, organization, flexibility of delivery, flexibility of adherence, follow-up, primary outcomes, and primary analysis. The eligibility domain asks, how closely do the participants in the trial represent the treatment population in usual care? For example, if an intervention in usual care is for patients older than 15 years of age with asthma, including all patients older than 15 with asthma would be very pragmatic. Excluding patients who do not meet age exclusions or have numerous comorbidities or patients with low adherence or poor follow-up history would make the patient population more homogeneous and the trial more explanatory. The recruitment domain asks, how are the participants recruited into the trial? For example, if patients are recruited through their usual appointments and routine clinical care for a condition of interest will be highly pragmatic. Using additional resources and means to recruit patients, such as media advertising campaigns or incentives such as cash payouts, vouchers, travel costs, and childcare will be more explanatory, as the recruitment of patients is not representative of usual care. The setting domain asks, where is the trial being conducted? Does the trial setting match routine clinical practice, and where will the results be applied? For example, implementing a trial in a setting identical to routine clinical practice will be the most pragmatic. A trial will be less pragmatic if the trial did not match the setting where the treatment will be administered. For example, selecting specialists in academic centers when the intervention is intended for primary care networks, or only performing the trial in a single center. When designing a trial, there needs to be consideration of the match between the setting of the trial and the setting where the results will be applied. The organization domain asks what expertise and resources are needed to deliver the intervention. In other words, how closely does available resources such as healthcare expertise and staffing levels of the trial match routine care? For example, a trial that utilizes the usual organization of care, such as existing healthcare provider expertise, staff, and resources, would be highly pragmatic. If the trial requires additional resources, such as more personnel, additional training, and education, would push the trial to be more explanatory. The flexibility and delivery domain asks, how should the intervention be delivered? In other words, how would the intervention be implemented post-trial setting? For example, a trial that allows delivery flexibility to providers of how to implement the intervention, like in usual care, will be highly pragmatic. Restricting which interventions are allowed, how to deliver them, and the specific situation would push the trial to be more explanatory. The flexibility of adherence domain asks, what measures are in place to ensure participants adhere to the intervention? In other words, how will the participants in the trial engage the healthcare setting intervention? For example, if there are no special measures to enforce engagement or compliance, like routine care, would be highly pragmatic. If participants are screened for adherence, or withdrawing patients with low adherence, or having a measure in place to promote and address adherence, would push the trial to be more explanatory. The follow-up domain asks, how closely are the participants followed up? For example, a trial with no additional follow-ups except usual care will be highly pragmatic. A trial that contacts a patient for missed appointments, data collection, or utilizes longer clinic visits with additional clinic staff would push the trial to be more explanatory. The primary outcome domain asks, how relevant are the outcomes to participants? In other words, are the outcomes measures important to patients and policymakers? For example, if an intervention is being tested to reduce falls in the elderly, then measuring falls will be an outcome relevant to patients and policymakers. A study that measures surrogate outcomes such as laboratory tests or composite outcomes such as incidence of death or renal dysfunction at 30 days will push the trial to be more explanatory. The primary analysis domain asks, are all the data included in the analysis? In other words, an intention to treat analysis where no patients are excluded and data are analyzed based on initial randomization assignment will be the most pragmatic. An analysis that excludes data from non-compliant recipients or non-adherent providers or from sites that do not meet the recruitment numbers will push the trial to be more explanatory. To demonstrate an application of the PRECISE-2 tool, a paper by Dr. Little and colleagues will be used. The authors estimated the effectiveness of commonly used strategies for advice on analgesia and steam inhalation for acute respiratory tract infections. Why did the investigators perform this study? Previous studies in ibuprofen compared to paracetamol or short-term and provide a limited assessment of symptom control and progression. Previous trials were performed in secondary setting, which makes it difficult to apply to the primary care setting. This study uses a randomized factorial design of interventions for respiratory tract infections. There are 3 drug groups, ibuprofen, paracetamol, or alternating ibuprofen and paracetamol. There are 2 dosages, regular or as needed, and 2 steam groups, steam inhalation or no steam inhalation. The inclusion criteria for the study included patients 3 years or older presenting to a GP or nurse in primary care with a respiratory tract infection. The exclusion criteria are patients with asthma, peptic ulcer, hypersensitivity to analgesics, inability to complete outcomes, conditions requiring hospital admissions, immunodeficiency, and pregnant or breastfeeding women. The primary outcome was symptom control, documented as mean symptom severity, measured at the end of each day. Average over days 2 to 4 of a 2-week symptom diary. The first few days are when symptoms of all respiratory tract infections are at their worst. Patients rated symptoms, with 0 being no symptoms at all, and 6 is as bad as it gets. This could include generally feeling unwell, sleep disturbance, fever, interference with normal activity, sore throat, cough, shortness of breath, facial sinus pain, earache, and runny blocked nose. On the eligibility domain, the study would score a 5, being very pragmatic. The study includes almost all those who would receive treatment as part of usual care. Pregnant women wouldn't be prescribed ibuprofen anyways, and there's a small proportion of patients excluded. On the recruitment domain, it would score a 5 as well, being very pragmatic. Patients were recruited at usual appointments only. There were no targeted recruitments or advertising campaigns. For the setting domain, it would score a 5 as well, because primary care are where usually patients go for advice and treatment. On the organization domain, the study would score a 3. Written intervention instructions are not typical of usual care, and also more staff were needed for follow-up diaries. On the flexibility intervention domain, it would score a 5. The protocol was identical to usual care. On the flexibility of adherence domain, it would also score a 5. There were no measures to improve compliance, and patients were free to not comply with advice. On the follow-up domain, it would score a 2. The follow-up required more extensive data collection. Patients were telephoned to check for any problems with diary completion. If no diary was completed after 2 weeks, patients were mailed a reminder and telephoned as necessary to document outcomes. On the outcome domain, it would score a 5. The outcomes measured in this study were very relevant to participants, such as symptom severity on days 2 to 4, which are typically the worst for a respiratory tract infection. On the analysis domain, it would score a 5. The analysis used was the intention to treat. The PRECIS-2 tool summary indicates the trial is pragmatic in 7 out of the 9 domains. Follow-up and organization of the resources for the study are more intensive than usual care. Pragmatic clinical trials answers questions relevant to clinicians, policymakers, and patients. These studies evaluate the relative effectiveness of treatment options in routine clinical practice, and the goal is to improve the translation of research into practice through engagement, partnership, collaboration of different parts of the healthcare system. Pragmatic clinical trials are not without their limitations. They may have more design, implementation, and analytic challenges compared to explanatory trials. A positive trial result cannot answer treatment, cause, and effect questions. What is being tested in a pragmatic clinical trial is a package of care. For example, how do different levels of resources, different methods of healthcare delivery, and varying levels of treatment adherence affect patient health outcomes? Why do we need pragmatic clinical trials? Traditional research rarely happens in a typical clinical setting, so findings are difficult to apply in real-world clinical settings. We also need to ask questions important to providers, patients, administrators, and policymakers. There is a need for patient-centered outcome research to improve patient care, decision-making, and the quality and responsiveness of the healthcare system. The goal of pragmatic clinical trials is to make evidence relevant by maximizing the applicability of evidence to usual care and to a wide variety of healthcare settings. The goal is to add context to the translation of research into practice. Pragmatic clinical trials leverages administrative data, such as electronic medical records and administrative databases, to reduce costs and time required to generate evidence needed for decision-making. Pragmatic clinical trials maintains the strength of explanatory trials through randomization. They use electronic health records, which allows for the efficient and cost-effective recruitment, data collection, and monitoring and follow-up. They test interventions in routine clinical practice. Pragmatic clinical trials addresses a different need than explanatory trials. Both are necessary for policy and decision-making. Pragmatic research aims to design trials that represent routine clinical care to enhance relevance and implementation. The use of electronic health records for data collection and follow-up helps mimic routine clinical care.